All right, everyone, let's talk about amyloidosis. Now, I know it's a topic that can seem a bit tricky, but trust me, it's absolutely crucial, not just for your exams, but for your future patients. In this explainer, we're going to break it all down so you really truly understand it, not just, memorize a few facts.
So, instead of starting with some dry textbook definition, let's begin with a clinical puzzle. This is exactly the kind of case you will see on the wards. You have a patient, long history of chronic inflammation from rheumatoid arthritis, and now their kidneys are failing. So, what on earth is the link? What connects these two problems? Let's find out.
The clue here, it's actually hidden within the immune system itself. A normal immune response is our best defense, right? But when it goes wrong, when you have that kind of chronic, smoldering inflammation for years and years, like in rheumatoid arthritis, well, it can have some very serious unintended consequences.
So what's the culprit in our patient's case? It's amyloidosis. At its very core, this is a disease of abnormal protein buildup. Essentially, the body's making a faulty protein that it just can't get rid of. And so this protein starts to pile up, not inside the cells, but outside the cells, accumulating in different tissues and organs.
Okay, here's a fantastic way to picture this in your mind. I want you to think of these amyloid fibrils as a kind of biological concrete. Just imagine this concrete being slowly poured into the very delicate, very complex machinery of your organs, into the kidneys, the heart, the spleen. What's going to happen? Eventually, it's going to clog everything up, bringing those vital organs to a grinding halt.
So you're probably wondering, how is this concrete actually made? Well, it's actually fascinating when you think about it. It all starts with a normal protein, a precursor. But because of some underlying disease, enzymes start to, chop this protein up in the wrong way. This process, it's called partial proteolysis, creates these weird, sticky, insoluble fragments. And what do sticky things do? They clump together, forming those rock-solid amyloid fibrils.
Okay, so we suspect it in a patient. Now what? How do we prove it? How do we catch this culprit red-handed? Well, there is a classic three-step diagnostic path that you absolutely must know for your exams. Step 1, you need a piece of tissue, a biopsy. Step 2, you stain it with a special dye. And step 3, you look at it under a very special kind of microscope. And this is the gotcha moment. This is the moment of truth in the lab. On the left, you see the tissue stained with Congo red. The amyloid deposits just look like these pinkish red smudges. But the real confirmation, the sign that is absolutely pathognomonic, is on the right. When you flip the switch on the microscope to polarize light, you see this beautiful, unmistakable apple green glow. It's called birefringence. When you see that apple green, you know without a doubt you are looking at amyloid.
Right, so now we've found the amyloid. We've got our diagnosis. But the next question, the really critical one, is where did it come from? What was the original precursor protein? And this leads us to the most important clinical classification, the two main phases of systemic amyloidosis.
Pay close attention to this table. This is super high yield for your exams. On one hand, you have primary, or AL amyloid. The L stands for light chains, immunoglobulin light chains. These are made by abnormal plasma cells. Think of them as antibody-making cells that have gone rogue, like in multiple myeloma. Then you have secondary, or AA amyloid. This comes from a protein called SAA, which the liver just pumps out like crazy during chronic inflammation. And this perfectly explains our patient's case, doesn't it? His chronic rheumatoid arthritis led to sky-high SAA levels, which then formed AA amyloid and got deposited in his kidneys. See how it all connects?
All right, let's move on. Let's see how this buildup of biological concrete actually hurts the patient. What happens when our vital organs come under siege from these relentless amyloid deposits? And this brings us right back to our patient at the beginning. The kidney is almost always the main target in AA amyloidosis. You can see here how the amyloid deposits just physically clog up the glomeruli, completely wrecking the kidney's delicate filtering system. This causes a massive leak of protein into the urine, a condition we call nephrotic syndrome. Another organ you absolutely have to know for your practicals is the spleen. It's a classic site, and you need to remember these two gross patterns. On the left, we've got the sago spleen. Here the deposits are more focal, and they look like little tapioca grains, like sago. On the right is the lardaceous spleen, where the deposits are more diffuse, more spread out, and look kind of waxy or map-like.
So what's the big takeaway here? The key thing to remember is that amyloidosis is a great mimic. It's a masquerader. The signs and symptoms depend completely on which organ is getting hit the hardest. If it's the kidney, you'll see nephrotic syndrome.
If it's the heart, it causes a very stiff, non-compliant heart, a restrictive cardiomyopathy. In the GI tract, a classic, almost pathognomonic sign is an enlarged tongue, or macroglossia. It can even gum up the works in nerves and joints, causing things like peripheral neuropathy or carpal tunnel syndrome.
Okay, we've gone through the pathology, the clinical signs, the whole shebang. Now, let's switch gears. Let's get into what really matters for you right now, your exams. How is this topic actually going to be tested? Let's look at a few examples you might see, whether it's your university exams or competitive ones like the USMLE or PLAB.
Here's a classic short answer question. If you get this, you should be smiling. Your model answer needs to follow this logical chain of events. Ready? 1. Chronic inflammation causes macrophages to release cytokines, especially IL-1 and IL-6. 2. These cytokines tell the liver to produce massive amounts of a protein called SAA. 3. This SAA is then partially chewed up by macrophages, which creates the insoluble AA fibrils. And 4. These fibrils get deposited in the tissues. That's it. That's the complete cascade.
Okay, let's try an MCQ. Now, in these questions, you have to hunt for the key words. What are they here? Multiple myeloma, congestive heart failure, and an enlarged tongue. Right. So multiple myeloma is a plasma cell problem, a dyscrasia. And what do those crazy rogue plasma cells pump out? They pump out immunoglobulins, specifically the light chains. Therefore, the precursor protein has to be the immunoglobulin light chain, which forms AL amyloid. So the answer is, of course, C. Listen, if you take away only one single thing from this entire discussion today, let it be this. Burn this sentence into your brain. It is the single most important diagnostic fact in all of amyloidosis. Say it with me. Apple green birefringence. It is the key that unlocks every single diagnosis.
And I'll leave you with one final question to really chew on. We've figured out how this amyloid is made, and it's made from our own proteins. So the deeper, more profound question is, why is our body so bad at cleaning up this mess? Why doesn't our powerful immune system just clear it away? Why do these